I'm Dr. David Levine, and today is May 18th, 2024. I'm in Boston, Massachusetts at the annual meeting of the American Association of Plastic Surgeons. In a nutshell, I have the honor of interviewing icons of plastic surgery who are teachers, authors, and innovative surgeons who have taken plastic and reconstructive surgery to the point that we are today. I've done over 40 interviews in the past 10 years, and today I have the distinct honor and privilege of interviewing Dr. William Kuzon. Bill, pleasure.
Thank you.
First question, what's your full name and date of birth?
Yeah, so my full name is William M. Kuzon Jr., born August 7th, 1955.
Okay, and your parents' names?
My father's name was William as well, William Michael, and my mother's name was Arlene Carolyn.
Any
Kuzon.
medical?
No, I'm not from a medical family. I'm from a working class family.
Okay, and you said you were born in Buffalo?
Yeah, I was born and grew up in the Buffalo, New York environment. Yeah.
You must
area.
like cold weather.
It's winter there sometimes. Yeah.
How many children, grandchildren do you have?
So we have 3 children. They are all in their 30s. I have an older daughter, Aniela, who is 38. My son Robert is 35, and my daughter Celia is 33. And we have Celia's married. She's married to her husband Stephen. They have 2 children. So we have 2 grandchildren, Genevieve and Madeline.
Okay, great.
Yeah.
How'd you meet your wife?
In high school. So we went to high school together. We were not a couple. We did not date in high school, but we actually rode the same bus and were in the same classes. And then the typical story, during freshman year of college, we each broke up with our high school, boyfriend or girlfriend, and then we started dating that first summer home from college.
Okay,
and
great.
So this year is 47 years we've been married.
And so the next question, we get a little bit deeper. And how did you decide to go into plastic surgery?
I know a lot of people tell the story about how they planned it out, but it was honestly, my entire career is a very fortunate sequences of serendipity. So I honestly went to medical school because I didn't know what else to do. I'm not from a family where my cousins and myself are the first generation of people who went to college. I didn't have any role models or mentors in my family that could tell me about a higher education. So I was good at school. I like science, kind of. So what do? You go to medical school, and without knowing much about it. I think in medical school it becomes pretty obvious if you're going to be a procedural person or you're going to be one of those cognitive specialties. And so I really like surgery. I liked anatomy, but at that time, surgery was a pretty toxic world. As a medical student, I had to be at the hospital at 4 in the morning. I rarely could go home before 11 o'clock at night. It was it was the quote golden age of surgery. It was quite a toxic environment. So just by chance, I did a plastic surgery rotation. The 3 plastic surgeons at Rochester at that time were well known. Bob McCormick, who was the association president, George Reading, who I believe was also association president, and Alethea Caldwell, who was a longtime association member. You rotate on, they're all really nice, and the surgery is super cool. So I thought, okay, I'll become a plastic surgeon.
Wow.
Yeah. It wasn't anything planned or preconceived, that obviously is so different from the situation now.
Yeah, but ultimately, you chose the academic route.
That's also completely serendipitous.
Okay.
So as I told you, before we started recording, I went to medical school in Rochester, New York, and I needed to stay close to home in Buffalo for family reasons. My dad had passed, and my mom was alone, and I couldn't go far away. So you look at a map, what's near Buffalo? Cleveland, Pittsburgh, Rochester, Syracuse. I looked at those places, and I went to talk to my chair of surgery about it, who was a man named Bill Drucker, one of the giants of surgery back then. And he had previously been chair of surgery in Toronto. He said, why don't you go take a look at Toronto? And so I went up there, and in those days, going across the border wasn't a big deal. When I grew up in Buffalo, we used to play hockey in Fort Erie every Friday morning. The border agents would just look in the car and see guys with hockey equipment and just wave you past. They didn't even talk to you. And so I went up to Toronto and looked, and there were lots of reasons I liked that program. Their training programs then were a lot like our training programs are now. The attendings are always in the operating room. There's some reasonable appreciation that you couldn't work 200 hours a week, and so in Toronto there's one medical school, one residency program. I trained with 45 different plastic surgeons. A huge advantage to training. So we decided we would go there, and at that time you only matched into in Canada you only matched into an internship. So I matched into an internship at Toronto General Hospital, and during my internship I had to apply to plastic surgery. I had only been there a couple months. I was very shell-shocked for a couple reasons. First of all, the Canadian medical students were much more prepared to become an intern than we were coming out of American medical schools. And then all of the trade names of the drugs were different. There was quite a bit of difference in the culture of medicine. So I applied to plastic surgery that year and I didn't get in. So now I'm in a foreign country and I'm on a work visa, and come June 30th, I don't have a job. So I went to talk to the person in Toronto who told me that it would work out, a guy named Bob Stone. He was in charge of the surgical residencies in Toronto at that time, and he eventually became chief of surgery in Halifax at Dalhousie. But he said, okay, right, I told you not to worry about it, and now the situation. So go talk to the chief of plastic surgery, and whatever he tells you to do next year, do that, and I'll pay your salary out of the department. So I went to talk to Bill Lindsay, W.K. Lindsay, who was the chief of plastic surgery. He said, go talk to Ralph Mankdalo, who was the chief at Toronto General Hospital. I went to talk to Ralph Mankdalo. He said, go talk to Nancy McKee. I went to talk to Nancy McKee. She said, sure, you can come in the lab. And that was the reason I ended up in a research environment. I'd never done anything before. I'd never had any interest. I was a very, I don't know about average, but I was I didn't expend any energy in medical school towards anything except I needed to do to get through school. So I went into lab, and that was
it's still not that easy.
Well, I went into the laboratory, and that was the spark for me. That was the difference.
What kind of, did you microsurgery?
It was a basic science laboratory. We did skeletal muscle and peripheral nerve research.
Okay.
And so that was I'm not sure I would even still be in medicine now, to be honest with you, if I had that sort of just completely random series of events hadn't happened. Nancy was just the most unbelievable mentor, friend. She's now passed away, unfortunately, but working in that lab and the excitement around the academic mission, and I stayed in the lab long enough to earn a PhD. And then came back and finished my surgery training.
That's right, public health, right?
It's my PhD is in community health because the program I was in was actually administered through community health, but it's actually, my PhD is actually in exercise sciences.
Okay.
So I essentially have a PhD in gym. And the reason for that was because those were the people on campus who knew the most about skeletal muscle mechanical function and skeletal muscle adaptation, and so we studied, reconstructive skeletal muscle physiology related to reconstructive surgery, free vascularized muscle transfer, denervation, reinnervation, tendon injury repair, those sorts of things.
Okay.
And so that was the thing that set me on this course of being an academic surgeon. I don't know. Honestly, I'm absolutely honest. None of this was planned.
Well, it's interesting because
There's no forethought at all. I always say my plan is to not have a plan, because it seems to have worked out pretty well.
Well, it's disconcerting to think that you only match for an internship. So that force, it's like the House of Representatives. Every 2 years you're running again.
Yeah.
So you had to be thinking about where am I going to go next?
Well,
and then a set of circumstances worked out for you.
If I didn't get into plastic surgery, I went in the lab, and then the next year I was accepted into the program. And if that hadn't happened, I don't know what I would have done. I considered just being a university professor, teach people in the School of Physical and Health Education. There were lots of opportunities. It just ended up working. It just ended up that this is the way it worked out. Yeah.
So my next question is, what do you feel during your career? There have been paradigm shifts in plastic surgery. Tell us a little bit of what you feel about them and what you think.
I'm older now, and so I'm supposed to hate the EMR, and I'm supposed to complain about all the administrative stuff, and I'm supposed to, not like the changes that they've made to the way healthcare is delivered. And it's not that I like them, but it doesn't change what we do. We still go in the clinic room, we close the door, we're in there face to face with the patient. We go in the operating room, we close the door, and it's still us and the team and the patient in there. Yeah. And, I think the changes in the delivery of healthcare at the surgeon's level, I mean, I'm glad I'm not a primary care doctor or something like that, but at the surgeon level, the fundamental of what we do hasn't really changed. The thing that I do think we need to focus on is how residency education has been challenged and changed. Our ability to give our trainees longitudinal experience, to give them hierarchical responsibility, independent responsibility in the operating room. This field is broader now, so that the opportunity to get them in-depth experience in each area has become more challenging. Then obviously that's a major national discussion, and there's lots of initiatives out in the way of surgical training. That is kind of I think that's the biggest change I see. And I'm supposed to hate the EMR, but the EMR, the people who don't like it, they must not remember what it was like before it. When I had to get out of bed and drive to the hospital to look at an X-ray, or
never thought about it.
Yeah, or I had to sign things, sign every note in the chart by hand. There were medical record rooms where you'd have to go, and there would be a stack of charts up to the ceiling with your name on it, with 50 of those little tabs in them, and you'd have to spend all day signing charts by hand. So, it's not that I like the fact that there's a lot more hospital administrators and that they try to treat us more like, revenue centers rather than, professionals. I'm not saying that I think any of that's appropriate, but, I try to focus on the fact the fundament of what we do hasn't changed.
How many residents do you have?
So our program is a 7-year program. Our residents do the 6 years integrated plastic surgery. They do 1 year of academic enrichment, academic development. It doesn't have to be research. It can be a degree or something. It has to be related to surgery. We train 4 per year. So 7 years, 4 is 28 residents at a time. Yeah.
So it's a 3 and 4 and 3 program?
The programs aren't constructed like that anymore.
They're hybrid.
The combined program was eliminated by the Board of Plastic Surgery some time ago. There was a big discrepancy in how the pass rates of the board exam and things like that from those combined programs. And so now all programs are integrated. So our residents, they do, I'm going to say it's probably about 1.5 years of rotations that aren't plastic surgery.
Okay, ortho, urology,
general surgery, so on, and then the majority of their time is spent in plastic surgery training. And that was a big, I guess that is a very big paradigm shift. You know, it used to be, as you said, a lot of general surgery experience and then plastic surgery. And actually took me a while to come around to the fact that our specialty is now more like ENT or orthopedics or urology. Yes. It is not as related to general surgery as it once was.
Yeah. Well, it's evolved. That's because
and general surgery is, of course, it's not even a specialty. It's a collection of unrelated subspecialties that is kind of chaos.
Yeah.
Right?
Well, it's interesting because your story kind of parallels my journey to where I got, because I was in a straight surgical program in Dallas at Baylor, and it was a pyramid program.
Right.
I didn't like general surgery. So I laughed when you said, I just never really cared for it. And they said, you're not going to advance in the program. So I had to go out and find a 2-year program, because I didn't find this out till a year before would have been my 4th year. I dreaded going into the next level because I didn't really want to do it. I found a program, straight surgical allowed you straight surgical 1, 2, so that was considered 3, which is really all I felt I needed.
Yeah.
I always got a kick out of people that got their boards in general surgery. I thought, what'd you do with that?
Yeah.
And then I went to Houston and then finished up in Akron, Ohio, and then did a hand fellowship up there.
Yeah.
And I liked the route I took.
Yeah.
It's like your story. You had to get a little bit lucky. They opened up another space that I got into the residency, and then didn't enjoy the one there because it was too new. So essentially had cosmetic surgery there, then went to Akron where I got to see everything else.
Yeah.
So it kind of smile at your story of figuring it out. You know, and it worked out for you. What do you feel the greatest mistake, and I think I know what you're going to say, our specialty has had?
Mistake. Well, I don't know. I think that our specialty gets derailed, I think, sometimes by the idea that you should subspecialize, that you should, especially in the past, you know, there was this big focus on you finish your residency, try not to even have any call, try not to just kind of build a cosmetic surgery practice. I think in the long run, that sort of thing will not serve the specialty well. And, you know, our challenges with our scope of practice related to, you know, oncoplastic breast surgery or orthoplastic, you know, lower extremity trauma reconstruction. I think that those, you know, are partly of our own making. The reality is the specialty is so broad now, no one is going to be able to do every aspect of it. But, you know, what we've done at Michigan, I think, is not a bad model. Everybody has a subspecialty that they focus on, but everybody also is expected to help load the truck. So we all see pressure sores and hidradenitis and wounds, and you know, by sharing that load and sharing that, you know, work any big healthcare system is going to generate, we have not. I don't think we've role modeled for our residents that, you know, you want to settle into 1 or 2 operations or you know, not you know, I mean. The healthcare system at large does not need us to do liposuction. That's not what they need us for. So I think that's the scope of practice battles, I think, are challenging. I think that partly, as I said before, is of our own.
Well, I didn't think exactly you were going to exactly say that, but I agree with that too. That we've kind of lost focus. My problem is the reason I retired was social media took over.
Oh.
I couldn't keep up with that. And I always got a kick out of people that went into practice and the next day they were world specialists in something.
Yeah.
Because that's what they had on Instagram. And that's what they had on Facebook. And watch me do this. And I thought, I kind of liked the old way of just working hard and doing it and doing everything that we were trained for, then settling down to what you want to do the most.
Yeah. I think that I mean, that's partly what I'm saying. I mean, fortunately, I'm in an environment at Michigan where we really don't have a social media presence. It's not necessary for us to have very, very, busy practices. Now there's either 17 or 18 or 19 of us. I lose count at Michigan, and everybody is, fully booked. And even our cosmetic surgery business is not. We can't keep up with it.
Amazing. Yeah. Things have changed. What do you feel has been your greatest joy?
I think that when you look back, taking care of patients one by one is, extremely gratifying. And we all remember those few cases that were just, somebody was in real trouble and you were able to help them. And then the thing that I think the happiest about, I managed to do that without messing up my family, at least without messing up my family too much. Our kids always came to plastic surgery meetings. They came to plastic surgery events at Michigan. They grew up in plastic surgery. Joe Losi gave a talk once that I thought what he said was very insightful. He said, if you make your work your life and your life your work, and you don't try to distinguish between those two, then there's nothing to balance.
Right.
And as a surgeon, what we do, there's gonna be some sacrifice. You're gonna miss some activities with your children or your family that you would otherwise want it to be there. But that, I think, you basically have to just decide you're only going to let that happen to a certain degree.
Gotcha.
And all of this focus on burnout and moral injury of physicians and all of that, I understand it's a real problem and that there's lots and lots of pressures, especially on younger physicians and surgeons. But it takes some, ego or force of personality to just say, I can't do this today. Somebody else can do it today. Yeah.
Who do you admire most, professional or personal?
Oh, that is a relatively, so my mentor in Toronto was Nancy McKee. I went into the lab with her, the most unbelievable human being I think I've ever had the privilege of having as a friend and a mentor. She's first of all, she's one of the very smartest people I've ever met in my life. She's humble beyond belief. She was just extremely ethical and not worried about personal fame or glory or that was truly inspiring to me.
Okay.
I spent 5 years in her lab. During my training, my program director, Ron Levine, is the person who taught me the approach to plastic surgery that has served me very well across a career. Very, very practical, way of not only making decisions, but of actually how to learn, how to study and learn and categorize information that we need to, we can't I tell our residents every single day, you cannot practice plastic surgery with your phone. You can't just Google everything and then assume and so you have to have this encyclopedic knowledge that you walk around internally.
Yeah.
And, Ron was really the person who did that for us, all of us in Toronto. There's lots of others, John Faulkner was the person I went to Michigan to work with in the research environment. My first chief at Michigan, Dave Smith, was just an unbelievable supporter and mentor for us early in our careers, especially. I mean, there's tons and tons of people.
Okay.
Yeah,
okay.
yeah.
Any words of wisdom for present and future generations of plastic surgeons?
Well, yes. So remember, it's an ultra marathon and not a sprint. No matter what venue of plastic surgery, what practice environment you're in, and especially if you're in the academic environment, it's a long time. So pace yourself, do things at a time. Don't feel pressured to do stuff you don't really want to do. That does take some ability to allow people to be disappointed in you. Not that you want to do that as a matter of course,
right.
but that's where I see people burning out. They're just doing too much stuff. They're too worried that if they're not at that meeting, they're not going to be there. They're not going to be part of the crowd. I actually talked to some of my younger colleagues at Michigan about this. One of my colleagues was trying to decide if he was going to go to a meeting in Japan in the fall when his wife will be like 8 or plus months pregnant.
Right.
Like, what's wrong with you? I don't understand that. And so, pace yourself. And, the other thing when I travel as a visiting professor is, make sure you get well trained, because that residency experience, you may not realize it now, but it stays with you forever, and you have to nail it down while you're still training.
Okay. Final question is, what predictions do you have for plastic surgery in the next quarter century? And please comment on AI and your feeling about that.
Yeah, so I actually know relatively little about AI. I think the word artificial is a good one. It's not real intelligence, it's fake intelligence. So it may help us, if it can generate a accurate, clinical documentation, that those sorts of things may be helpful. But I think at least as existed up to now, it's not helpful for algorithmic diagnosticians and stuff. In plastic surgery, we're not really diagnosticians anyway. We're anatomists, right? When someone comes into the ER with a cut off finger, you don't work up a differential diagnosis first, So I think that the future of plastic surgery.
Yeah.
I hope that we continue to recognize our place in the surgical world, which is to solve all of those surgical problems that our colleagues send us, all of their complications, all of their reconstructive challenges, and that we will not lose sight of that as the reason that we are important in big health care centers, even in any community. That is what I was alluding to. I think has gotten the message coming from our national organization sometimes has gotten off of that to some extent. So, and they talk about plastic surgery as innovation. You read about the real innovations and how they came about, and about the big advances that we've had. They're mostly a coalescence of a lot of small incremental gains of knowledge. So, now the focus of plastic surgery is entrepreneurship, and we're gonna move everything, from the bench to the bedside. I hope we don't lose sight of the fact that it's those little incremental increases in knowledge are really what enable those big advances when they come. And I think it's hard to predict what they're going to be.
Okay.
I mean, I will tell you, I feel so fortunate to have chosen plastic surgery and not vascular surgery or cardiac surgery, where I got to run a catheter up and down somebody's vessels instead of operating on them, or general surgery where I have to watch my operations on a TV screen across the room because a robot's doing it, or we're still open soft tissue surgeons, bone and soft tissue surgeons, and so I hope we don't lose sight of that.
Yeah, I smile because that's the fun thing about plastic surgery.
Yeah.
Is doing it.
Yeah, we only know, that's the only thing we know how to do.
Yeah.
Right? We don't treat deranged physiology. I don't treat people with courses of chemotherapy and, complicated management of their metabolic derangements, diabetes or whatever. We operate on people. That's what's so great about it.
Well, to cut is to cure.
Yeah, absolutely. Yeah.
Well, Jim, it's been an honor and a pleasure to interview you today. If you have anything you want to bring, anything else, or are you good?
No, I'm good. This has been great. Thank you.
Thank you so much. Thank you. Thank you so much. And I hope you enjoyed this interview. All of my interviews are available online at meeting.aaps1921.org. I'll repeat that. meeting.aaps1921.org. And thank you.